in spine tonight, who will be talking about spine trauma. This is the first of 3 spine lectures that we'll be giving throughout the summer. Dr. Margetis is assistant professor of neurosurgery in our department and the chief of neurosurgery at Mount Sinai Morningside, which is where the bulk of our trauma is handled. He's also the director of spine at Mount Sinai downtown Union Square. I'm not going to spend much time explaining the landscape and geography of Mount Sinai. It's fairly sprawling. He completed his medical education and residency in Greece and then came to the US, where he did a pediatric neurosurgery fellowship, which was where I first encountered him at Weill Cornell, and then a fellowship at the Cleveland Clinic in complex spine and deformity surgery. He has a wide array of publications and frankly is just an exceptional human being and a great surgeon and a good person to work with. So I'm very happy to have him here tonight. Dr. Steinberger, equally great person, who I've also known for a very long time since we were applying to residencies together. He completed his training here at Mount Sinai and then went off to do an orthopedic spine fellowship for a little bit of balanced education over at the Hospital for Special Surgery. He's been in New York for an awfully long time and has won a number of awards for patient care, research in spine surgery, and for his personality in the hospital, to put it simply. So these two will give you guys a very engaging lecture on spine trauma, and I will turn over the screen to them.
Thank you, Peter. Hello, everybody. Can you see my presentation?
Yes.
Oh, okay, very good. So I will start discussing about spinal cord injury and cervical spine trauma, and then Dr. Steinberger will discuss about thoracolumbar spine and some surgical techniques. So I will start with a very quick case. This is a 63-year-old lady that she was brought in after falling down from a swing. Unremarkable past medical history, and the ED attending called me that she has some movement of the biceps and deltoids, but nothing below that. The sensation, the upper extremity is impaired, no sensation in the legs, and no rectal tone or any kind of perianal sensation. And that lady got a CT scan that showed this 3, 4, 5, 6, 7 dislocation with bilateral jump facets, as you can see here. And we attempted to do a closed reduction, and you can see here the jump facets, and then you can see here as we're trying to reduce the dislocation with the traction that it came very close, but we couldn't really go this extra 2 millimeters and reduce the fracture. Peter, can you see my pointer?
Yes.
Okay, very good. So we're trying to reduce it, but we're not able to. So what we did is we flipped her prone, and we did an open reduction of the dislocation. And you can see here we have placed a Woodson elevator, and we're palpating the ventral epidural space, because sometimes when you do that reduction, you might end up with a big disc herniation. And we inserted that instrument to confirm by palpating that there was no disc herniation. And you can see here the instrumentation that we placed, and this is the post-op MRI that it shows extensive spinal cord edema, and you can see that there is no disc herniation, which is always a concern when you try to reduce these fractures through a posterior approach. And you can see that we also did here a laminectomy to give more space for the spinal cord to swell, and we'll discuss about these decompressive options that we have in spinal cord injury. So after this small case example, I would like to discuss a few things about the pathophysiology of spinal cord injury. So we have the primary injury that happens at the moment of the accident, and there are various mechanical types of injuries that can happen: shear, stretch, contusion, laceration. But on top of that, then we have the secondary injury, pretty similar to what happens in the brain with traumatic brain injury. I would like to emphasize these mechanisms, the edema, the ischemia, because these are probably the mechanisms that we can intervene to reduce their effect on the recovery of the spinal cord. The edema, we can reduce the effect by decompressing the spinal cord, the ischemia by maintaining a good blood pressure and optimum spinal cord perfusion parameters. One additional mechanism for the spinal cord injury that doesn't apply to traumatic brain injury is that we may have additional primary injuries. If the spine is fractured or dislocated, then the bones, as they move, they might cause additional primary injury. That's why we need to immobilize the spine, and that's why we need to, if we're gonna reduce the fracture, we need to do some kind of fixation to make sure that the bones will not move out of the normal position and cause additional injury to the spinal cord. And about external mobilization, that takes us to our next slide. So any patient that has suffered spine injury or has a mechanism of injury that has a high potential to cause spinal injury, they need to be immobilized. Also, we need to mobilize patients that they have impaired level of consciousness, because we cannot rule out a spinal injury. So this is how the patients are brought in by the emergency medical services. You can see that they have a rigid collar, they have a backboard, and the head is also stabilized with these additional bolsters next to the head. For penetrating trauma, it's not necessary to have a cervical brace because it's rarely associated with spinal instability. And the brace in the neck might delay the recognition of hematomas that might threaten the airway, or it might delay the recognition of dangerous hemorrhages. So in penetrating trauma, we don't place a brace, but for other types of trauma, we do place a brace. We need to remove the spine board as soon as possible because there's a high risk for the patients to develop pressure ulcers if they remain on the backboard. And you can see here how the backboard was removed. And any kind of movement, any kind of rolling of the patient, we need to use the log roll technique, which is nicely demonstrated here. So you see one guy is holding the head, one is holding the chest, and one is holding the pelvis and the legs. So the whole body needs to be, the whole trunk and neck and head needs to be rotated without any kind of flexion, extension, or rotational maneuver. So some important points. So in elderly people, they might have a baseline cervicothoracic kyphosis, as this guy here has. So these patients, they need some head support. If you try to immobilize these patients just with the backboard, you're basically kind of forcing the neck in an extension. So remember that in elderly people, you might have to put some additional padding underneath their heads. The opposite applies for kids. They have a big head in relation to their bodies. So you might have to put some additional padding under their bodies to prevent any flexion of the neck, because you don't have that padding that you can see here. Then the neck comes in a little bit of flexion because the head is much bigger than the body compared with an adult patient. So the first thing that you need to do is, pay attention to the ABCs. Patients who have spinal cord injury, very frequently they have hypotension, which you need to correct as soon as possible. And in general, our target is mean arterial pressure between 85 and 90 millimeters for approximately 7 days. That will ensure a good perfusion of the spinal cord. And that's usually done in an ICU or a monitor bed setting. And why do they get hypotension? Because they very frequently get neurogenic shock, which is common in injuries above T6, rare in injuries below T6. It has to do with impairment of the sympathetic outflow. And it will present with hypotension. And the main way to differentiate hypovolemic shock versus neurogenic shock is that in the neurogenic shock, the patient will have bradycardia, or they might have hypotension with a normal heart rate. So they don't have, they cannot mobilize this compensatory tachycardia to fight the hypotension. And massive fluid resuscitation is not really the correct way to treat that. These patients, they need vasopressors like dopamine, is the first agent. And if during the intubation or during some other maneuvers, you see that they develop significant bradycardia, they might need additional atropine to fight the bradycardia. The clinical evaluation is based on this American Spinal Injury Association classification scheme. It looks a little bit complicated, but actually it's not that complicated. What we need to do in the acute phase is just grade the motor strength in some key muscles, and they are here, these muscles, and also assess the sensory function in some key dermatomes, which are delineated here, and also check for voluntary anal contraction and for deep anal pressure. After you have done that, it's very easy to calculate the sensory neurological level, which is the most condyle intact dermatome for sensation. Calculate the motor level, which is the lowest level that the muscle has anti-gravity function. And then based on that, you calculate the neurological level, which is the most caudal segment of the cord with intact sensation and anti-gravity muscle function. And then we characterize the injury as complete or incomplete based on if the patient has preserved sacral nerve root function or not. And based on that, we then calculate the ASIA impairment scale. A means complete injury. B means that there is no motor function below the area of the injury, but there is sensation. C means that there is motor movement, but not enough to grade it as D. And D means that more than half of the muscles have at least anti-gravity strength. And E is normal. So, you know, sometimes I hear from the ED or people who don't have experience. I have a patient with a spinal fracture that is ASIA E. And what they want to communicate with that is that the patient's intact. But that's not the correct way to communicate that. ASIA E means that somebody had a neurological deficit and now has fully recovered. If somebody never had any kind of weakness, he doesn't qualify for a spinal cord injury. So this classification scheme does not apply. Now, one quick reminder that, for example, a spinal fracture at the T7 level doesn't necessarily mean that there will be a T7 myelotome injury, because the spinal cord is shorter than the spine and it terminates, as we know, at L1, L2 levels. So the myelotome levels do not correspond to the vertebral levels. So just keep that in mind. So a few words about some incomplete spinal cord injury syndromes. We have the central cord syndrome, which we more commonly see that in elderly people, that they have some pre-existing stenosis and they have a hyperextension injury. And what we think it happens is that most of the edema is concentrated in the central part of the spinal cord, where the nerve fibers and the pathways that have the motor fibers that go to the upper extremities are located. So that's why we see in these patients greater motor deficit in the upper extremities than the lower extremities. Then we have the anterior spinal cord syndrome, which basically is a vascular injury. It's more like a stroke, the anterior spinal artery, which perfuses the anterior 2/3 of the spinal cord. This has the worst prognosis because, again, it's more like an ischemic type of injury to the spinal cord. And then we have the Brown Sequard, which is basically injury to 1/2 of the spinal cord. So for the patients who have spinal cord injury, we always do a CT scan of the cervical spine. And we have here some criteria, either spine pain, any radiating pain, or any kind of weakness. We do the CT scan in the awake patients. In patients who are in coma or who cannot examine, we always get a CT scan to rule out cervical spine fracture. Some words about pediatric trauma. So, a common mistake is to think that synchondrosis between the ossification center represents a fracture. So all these are not really fractures; they're just the synchondrosis between the areas where the ossification of the bone starts. Another thing is the distance between the dens and the C1 is a little bit increased in kids. It's 5 millimeters. So if it is 5 millimeters or less, it's normal. While, in an adult, if it's more than 3, we consider that abnormal, and it's a sign that the transverse ligament is ruptured, which suggests a very unstable injury. Also in kids, we have this C2-3 subluxation, which is a normal variant, and it doesn't represent a true spondylolisthesis of C2 over C3. Also, in cases where we suspect vertebral artery injury, we have a very low threshold to get a CTA, specifically in C1, C3 fractures, if there is a subluxation, or there are fractures that they involve the transverse foramen, as we can see here. And here is a CTA, and you can see the vertebral artery on this side, and it's absent on the other side because it's occluded. In regards to the classification, AO Spine came up recently with this kind of comprehensive simplified classification scheme. It has not been validated yet, and we still don't have any kind of recommendations on how to treat the specific injuries. But it's a good classification scheme to communicate some important principles. So over here, you see that all these injuries are just isolated bony injuries without any kind of dislocation of the bones. Most of these injuries can actually be treated with just bracing. They're relatively stable injuries. On the other end of the spectrum, we have type C injuries where we have dislocation, and all these fractures and dislocations require open reduction and fixation. And then in between, we have ligamentous injuries. So ligaments do not heal reliably. So when we have a definitive rupture of some important ligaments like the alar ligament here, or the transverse ligament here, most of the times we proceed with surgical treatment because these fractures, these ligamentous ruptures will not heal, and the patient will remain with an unstable injury. So in these cases, we always favor surgery if the patient is a good surgical candidate in terms of his systemic comorbidities. For the subaxial spine, AO has also came up with a classification scheme. And again, we have type A compression injuries, which most of the times we can treat conservatively, probably with the exception of this complete burst fracture that might lean towards surgical treatment. In type B injuries, we have some kind of disruption of the ligaments of the spine, and type C are dislocations. For the subaxial spine, we have one more category, the facet injuries, which are require some special consideration. We have some stable injuries and some very unstable injuries that, like this, as we call floating lateral mass, where basically there are two fractured lines that separate the lateral mass from the rest of the vertebra. And these are unstable injuries that require surgery. This is another classification that it's important to be familiar with. It was introduced in 2007, is the SLIC classification. And although there are many exceptions to that rule, that it still communicates some very important principles. So basically this classification, it asks you to grade the injury based on the morphology, based on the status of the discs and the ligaments, and based on the neurological status. So you sum up these scores, and if it is less than 4, then you can treat that without surgery. If it's more than 4, you need to do surgery, and 4 is the gray zone. So as I said, there are many exceptions to that rule, but what is important here is, for example, if you have rupture in the ligaments, again, you need to lean towards surgery. If you have incomplete spinal cord injury, this is a stronger indication to proceed with surgery than a complete, because there is higher potential for recovery in incomplete spinal cord injury. And also there is a higher risk if you don't do surgery. The patient can deteriorate if he has an incomplete spinal cord injury and progress to a complete, versus if he already has a complete injury, then there's no much room for deterioration. Also, if there is ongoing spinal cord compression, then you should also lean towards surgical intervention. Now, a few words about the options that we have to immobilize the spine externally. We have this Miami J collar. Then we have various types of cervical thoracic orthosis, like this Minerva type of brace. Then we have the halo, where we put pins and provide some more rigid immobilization, which in the past we used to use it much more often, but nowadays its use is much more rare, but it still remains an option for some C1 or C2 fractures. And then we have the cervical traction, which we do with the Garner-Wells tongs. A few words about steroids. So there have been several interpretations of that same study from 1990, and there is a lot of controversy. Initially, they said that steroids are an option, that they said they're not recommended, that there was another more recent publication that reintroduced the option. So when we talk about steroids, we're talking about mega doses of methylprednisolone. Nowadays, I think that most trauma surgeons will be a little bit reluctant to offer that to the patients, because we know that they have, there's a high risk by giving this high dose of steroids. And we also know from the TBI literature that high dose of steroids, they're associated with a higher mortality. So I think that very few people nowadays will give these high doses of methylprednisolone in spinal cord injury. What we do sometimes is give dexamethasone, but in more, let's say, normal doses, like 10 milligrams bolus, for example. Now, spine surgery. So what are the goals of spine surgery? The first goal is to decompress the nervous tissue, and there are various ways to decompress that by reducing the fracture, remove any bony fragments like this one that was inside the canal, and we remove that. Do a discectomy if there is a massive discrimination after the injury, and do a laminectomy, as you can see here, to evacuate any hematoma, and to decompress the spinal cord from any bony fragments from the lamina. Another newer concept is to do a duroplasty to provide an even wider decompression of the spinal cord, because the dura might still have some constrictive effect on the spinal cord. And then you need to do the definitive spine stabilization. There are basically 3 techniques: the osteosynthesis, where you put screws across the fracture line, but you don't fuse levels. Then you have the instrumented stabilization where you put screws, but you don't fuse, you don't do any decortication, you don't put any kind of bone graft, and you can go back a few months later, remove the hardware. And then you have the instrumented fusion where you put the hardware, but you also put bone graft and you want these bones to fuse together. And another goal is you want to achieve anatomical reduction. You see here this dislocated C2 from a hangman's fracture that it was reduced after the operation. So what's the optimal time for the surgery? I mean, it has been recognized over 100 years ago that you need to intervene early. And there's some recent publications that they push the limit to operate within 8 hours. And we know from the TBI literature that there is a time window of 4 hours for some dural hematomas, that if you operate later than 4 hours, the mortality, as you can see here, really increases. So from our small experience from Elmhurst Hospital, which it's a very important part of our neurosurgery residency program, we saw that there might be an effect if you operate really on and decompress the spinal cord really fast. So the general principle is that you should try to do it as soon as the patient is medically stable to undergo the surgery, and this is a concept similar to time is brain. But you need to be aware that you need special equipment. You need to make sure that you have all the equipment available. And you need to remember that spine operations, that they're done in the prone position, they might take long, they might be associated with significant blood loss. So if the patient has an abdominal injury or thoracic injury, the trauma team will not be able to do at the same time with you. They won't be able to open the chest or the abdomen to address a thoracic or abdominal injury as they can. If there's a TBI, you can do the craniotomy and they can do the laparotomy at the same time, for example. So the overview of the management is you need to maintain good blood pressure, make sure the oxygenation is good, immobilize the spine with a bracing until you're able to do the decompression with surgery or close reduction, and provide definitive stabilization of the fracture and make sure that the patient goes to a proper rehabilitation center. A few words about the prognosticators, their clinical factors. There are some imaging factors which have to do with the length of injury, how extensive is the edema in terms of the levels of the spine, and also the basic score, which basically grades the edema in terms of how extensive is in the axial view of the spine. And there are some also research prognosticators like biomarkers. All that is more like in the research phase. And also there are many unknown factors with these treatment options here, how they can change the prognosis in spinal cord injury. So a few words about delayed complications. Patients who have spinal cord injury, they can develop syringomyelia, which is a very bad complication because it can cause additional neurological deficits proximal to the spinal cord injury level. And the usual treatment is to restore the CSF flow around the spinal cord, or in some other cases, do some kind of sanding operations. My favorite procedure for that is the syringo-pleural sanding. So we put a catheter inside the syrinx and it drains into the pleural cavity. Another complication is delayed instability. So this guy had a type 2 dense fracture. We reduced that and we placed him on a Minerva brace, and it looks good in alignment, but in the follow-up 2 weeks later, we see that he developed a delayed instability and he had to undergo an orthodontic screw to stabilize the fracture. Another problem is the retained bullet fragments, because they don't allow you to get MRIs, and because the bullets contain lead, they can cause long-term lead toxicity. So most of the times I try to remove the bullets to prevent these delayed complications, and most trauma surgeons, we have this very sad collection of bullets retrieved from patients. So some emerging concepts. So there is a lot of research about CSF diversion. By removing CSF, we decrease the pressure around the spinal cord, so we increase the perfusion of the spinal cord. So it's a similar principle to the cerebral perfusion pressure. Okay, that's but what we can do in the spinal cord, we can reduce the intraspinal pressure by diverting the CSF. Another concept is the expansile duroplasty, as we said, to minimize the constrictive effect that the dura might have on a swollen spinal cord. And there is some research about monitoring the pressure, or some people have even suggested to do a myelotomy to relieve the constrictive effect that the PIA might have on the edematous spinal cord. And there's also research about hypothermia and riluzole, but that's not standard of care right now. So a few words about placing scaffolds. So actually there is a clinical trial that we participate, and we place the scaffolds in the area of the injured spinal cord. The goal is, and what we hope that this will do is to provide guidance for the nerve fiber regrowth. It's still, something that it remains to be seen whether it will make a difference in these patients. But animal experiences are very, very promising. So hopefully that will help our patients. In regards to restoring the spinal cord injury, there is also a lot of research with either neurotrophic factors or implanting stem cells in the spinal cord. There are various sources for the stem cells. Our interest is more embryonic stem cells, and we hopefully will be able to participate in a study related to that. And there are also neurotrophic factors that you can administer to induce a regenerative effect. Another interesting technique is the epidural spinal cord stimulation. So around 9 years ago, they reported that a patient with ASIA-B was able to walk, which is really, really impressive. And then there were 3 other publications more recently that they reported in case series similar effect, that patients, even with complete spinal cord injury, that they regained their ability to walk. So how did that happen? So basically, I don't think that these patients developed the ability to move their legs voluntarily and do the full range of motions. They were able to walk. And what we think that happened is that there was an activation of some nerve fibers, that they were able to activate some central pattern generators at the spinal cord level, that they're able to produce the walking movements. So that takes us to some newer concepts about the spinal cord function. So in the past, we used to think the spinal cord is just a nerve that only conducts information. Then later we found out that it's the center for some reflexes, but now we tend to think that actually it's an active computational node. And we also know that it's actually involved in plasticity of the central nervous system. And for example, we have seen patients have spinal cord injury that they develop atrophy of some parts of the brain. So its role is probably more important than we think right now. And all this ongoing research hopefully will help us understand more the function of the spinal cord and help us treat this devastating pathology better.
Well, you talk about how awesome Khan is. Just look at how he finished at 8:30 on the dot. That's impressive.
We had one question before we go on with Jeremy. For penetrating injuries, what are the typical indications and goals of surgical intervention? If there's anything else you want to add from what you already said.
Sure, yeah. I mean, for penetrating injuries, most commonly is from gunshot wounds. So we apply the same principles. We need to decompress the spinal cord. If there is ongoing compression, we need to stabilize the spine if the bullet has caused an unstable type of injury. And the only additional, there are actually 2 additional considerations. One is if there is ongoing CSF leak, we need to address that because that might lead to meningitis. And if there is a retained bullet it is surrounded by CSF, then there is this risk for delayed lead toxicity. So you might want to remove the bullet to reduce the risk for delayed lead toxicity. If none of these indications apply, then you don't necessarily need to operate for penetrating spinal cord injuries.
And the one other thing I just want to mention to all the attendees, if you're going to put in questions, do us a favor and just put them in the QA box instead of the chat box, as that'll make sure that everyone can easily see and answer them, because in the chat box, sometimes they're just addressed to the panelists or just the attendees. So this will be more consistent. All right, thanks everyone. We'll go on with Dr. Steinberger's talk.
Good evening, everyone, and thanks for attending this this educational seminar. I'm going to talk about thoracolumbar trauma, but often in a trauma setting, it's not usually as straightforward as memorizing this one scale. So I'm going to walk you through a case that actually was relatively recent with an unfortunate ending, but basically, this patient came in, a 30-year-old male, unhelmeted motorcyclist truck. And actually in Manhattan, there's not that much high speed trauma like, highway injuries and stuff. So that's one thing we don't see as often as other places in the country. But this was a 30-year-old unhelmeted motorcyclist truck, came with a GCS of 9. The only remarkable finding on exam was that and I've never heard this before, but the ER resident said she felt a palpable step off on his back. And I had never, have never heard that in training or in attending life. So I'm going to go quickly through his case. And because there are so many, this was basically a extremely traumatic, presentation, and so many things were happening at once that, it's a good case to show how things are in trauma sometimes. So the end of the story is he passed away due to brain death. This is the scan we did to prove brain death. The reason I start with the end is because I think even in a disturbing and sad ending of a 30-year-old who died, I think we can try to get whatever positive from it. And if the positive from it is learning from his case and ways we can do better in the future, then I think at least we gave his life some meaning at the end. He also did donate his organs, which did benefit other people. So this is like a classic, something you see, when someone comes in with a major trauma, is they get a pan scan. So CT chest, abdomen, pelvis, the head, the C-spine, the T-spine, the L-spine, the facial bones, and then a chest x-ray for intubation. And, this is the first image. So there are about 25 people in the CAT scanner because this is the highest level of trauma. It's very obvious. This is a high speed trauma with high morbidity. So this is the first image that I was able to see, and it was evidence that at some point in the past he had prior plating of his skull for whatever reason. But there's also fractures in his skull base, as you see here and as you see here. And there's a fracture in his sphenoid wing. There's a fracture going into his carotid canal. And this is obviously a major cause for concern because you can get carotid arteries or vertebral artery injuries in these kind of high-speed trauma or dissections. He also had left-sided proptosis with infiltration of the retrobulbar fat, consistent with the hematoma. He also had a left blown pupil, which we attributed to this. So it was not a blown pupil from intracranial hemorrhage, which is what we first thought when he came to the ER. So on his CAT scan of his head, actually, there was some small amount of subarachnoid hemorrhage, but overall, it wasn't, nothing we need to rush to the operating room for. And then the next scan to come up is a CT of his cervical spine. And, the first thing you might notice is this little fracture of C1. Doesn't look all too important until you realize that fracture goes right into the foramen transversarium where the vertebral artery lies. So there's, one cause for concern. The next thing you notice is he has a C2 fracture going across the dens, the base of the dens. Then C6, he has an inferior facet fracture, and you see that the normal facet should be like this. This is the facet where the two vertebrae interarticulate with each other, and this one is splayed open. So there's some sort of unstable fracture there. He also has a spinous process fracture. But more concerning than anything I've said so far is if you switch the windows from the bone window to a soft tissue window, and just to orient people who don't have as much experience looking at scans, the eyes, the nose, the mouth, we're looking from the side. This is the spine. So this is the vertebrae, the disc, and the bones in the back. And here's the spinous process fracture. But there's also this kind of hyperdense material on the CAT scan. And in this setting, that looks like an epidural hematoma. So now in addition to his multiple C1, C2, C6, C7 spine fractures, he also has an epidural hematoma in front of his spinal cord. Basically, I mean, the radiologist called it C2 to T2, but I think the bulk of it was really C6 and C7, maybe down to T1. So a very, very severe injury. And you see it on the axial image. You're looking up into the spine here. And this, actually, I think all of this material here is epidural hematoma, and the spinal cord should be occupying this space here. So we're thinking this guy has to go to the operating room, but let's finish his scan. And just to look at two different images of his C2 fracture. and his facet fracture on the right side at C6. So we're thinking he has to go to the OR. He has a C2 fracture, C1 fracture, and a suggestion of epidural hematoma. And then he gets his CT chest, abdomen, pelvis. So he hasn't gotten his CT thoracic spine, CT lumbar spine, but now you see this major, major injury here. And this is what the ER resident was astute enough to palpate. She said that she felt a palpable step off in his back. And, this, before we even scan the thoracic spine, now everything we've seen until now is basically pales in comparison to this injury. This is an extremely high mechanism of force injury. To get this injury in a healthy 30-year-old male requires a massive vector of force. And then you see now, you see a vertebrae, a disc, a vertebrae, a disc, a vertebrae, a disc, and then you see this massive disc, basically because he's dislocated his spine. And obviously that goes along with spinal cord injury. Here you see that, again, if you compare it to the ones above and below, you have a facet. So you have the inferior facet, the superior facet, the inferior facet, the superior facet, and then you see here, this is a facet dislocation. And this here would probably be a jumped facet where the facet jumped over the vertebrae above and dislocated. And again, even more concerning than everything we've seen so far, there is this hyperdense material. Now, this was read as epidural hematoma, but it also might be disc material. It might be both. But certainly in a spinal cord that runs like this, you're going to have severe kinking and severe injury to the spinal cord at this level, which was T11-12. So he has jump facets at T11-12, a fracture of T12, traumatic fracture dislocation at T11-12. So basically, to summarize, we have skull base fractures, orbital hematomas. We have multiple cervical spine fractures, a cervical epidural hematoma, a traumatic dislocation at T11-12 with an epidural hematoma. So the question is, what do you do next? So these decisions are made within about 10 minutes and you factor everything in, you try to do the right thing for the patient. So for this patient, our plan was to go to the operating room, evacuate the epidural hematoma in the cervical and the thoracic spine, and then stabilize both injuries, which we deemed unstable. And we'll talk about that in a little bit. So we brought him to the OR. His blood pressure in the ER was about 80/40. But when we got to the OR, his systolic blood pressure dropped to 40/20. This is before we started, before we put the patient in position, luckily. And basically, efforts were made to resuscitate him, basically. But it took about 40 minutes to get his pressure up to about 80/40 again. So he had something going on, which I'll touch on in a little bit. But basically, this blood pressure, we couldn't, despite giving him blood and despite putting him on actually 3 pressors, we couldn't get his blood pressure up for a long time. So this was, a devastating situation because he has these injuries that are likely going to cause him quadriplegia, but he's not stable enough to undergo the procedure. And we actually aborted the procedure and brought him upstairs to the ICU, temporarily aborted in the sense that our plan was to stabilize and make sure everything's okay, maybe repeat a scan and then bring him back when he's stable. So is this spinal shock? The answer is you don't know until you see the rest of his vital signs. So, but what is spinal shock? Actually, I'm going to skip through this because Con already spoke about it. But basically, I'm going to skip all this for the sake of time. But basically, the key for him was that he was actually tachycardic. So he was hypotensive and tachycardic. So he may have had some sort of combination. Spinal shock is complicated as it is, and I think it's very poorly understood, including by me. I feel like I don't fully understand spinal shock, and often when patients have it, it presents in not the textbook way, but you're kind of chasing numbers up and down. But in this patient, I thought he had a combination of hypovolemic shock because he did bleed a lot. He also had a big forehead laceration and that bled a lot while he was waiting for EMS. In combination with spinal shock. But I think the fact that his heart rate was so high, it was in the 130s, I think this was more of a hypovolemic picture than a spinal shock or neurogenic shock picture. So unfortunately, when we brought him up to the ICU, he blew his other pupil. So he had the left blown pupil because of trauma to the eye and from the retroorbital hematoma, but now his right pupil was blown. So we rushed him down to the OR to get a CT and a CTA of his head and neck. And that CT head, unfortunately, showed a lot of dusky area. So this is not as, gray and normal. It's just, it's early, but it's starting to show some serious hypoperfusion. And when you get hypoperfusion to the brain, this is a spine talk, but when you get hypoperfusion to the brain, then the brain swells and you can have midline shift, you can herniate. And this patient, unfortunately, had left uncle herniation and transtentorial herniation. So now we have a patient who has bilateral blown pupils, no brainstem reflexes. His CTA showed a carotid injury and a vertebral artery injury, a cervical epidural hematoma, and a thoracic epidural hematoma with unstable injuries in both. So, in this situation, I think it's very important to have some guidance for decision making, and that's why Khan showed the SLIC scale. I'm going to show the TLIC score, because when you're juggling 15 different things, you're trying to make decisions. You look at some of these guides for how to make decisions. So the TLIC score is designed for thoracolumbar trauma, and it looks at three things: morphology of the injury, integrity of the posterior longitudinal ligament, and the neurological status of the patient. So basically, morphology, in our case, which with a traumatic fracture dislocation, this would be a distraction injury and a score of 4. The integrity of the ligaments, all of his ligaments were torn, so he would be an injured, which would be a 3. His neurological status, unfortunately, due to his intubation and his GCS9, we didn't have a great exam. He was not moving his legs, so we were probably going to give him a likely 2, which would bring the score to 9. And this should be a greater than sign, so I just noticed that. I apologize, but less than 3 non-op, 4 is questionable, and greater than 5 op. So he's clearly in the operative category, but that's obvious. Sometimes it's an obvious, you don't really need to reference the score. And then the Asia score, Khan already covered. And that's basically where I want to end that case, which was obviously very traumatic for everybody and a bad outcome. I'm happy to answer any questions, and then I'll shift gears for the last probably 5 minutes and talk about happier things. If there's no questions, I'll just keep going. So basically,
hi, Dr. Steinberger.
Yes.
Yes, hi, my name is Clementine, and I have basically 3 questions, if that is okay. So the first one.
Why don't we start with one so that we have time to get through the talk, and if there's time, you can get to the others at the end.
Okay, all right, no problem. So I wanted to know, in this patient, you considered his hemodynamic stability, and the severity of his injuries, and your team decided to proceed with surgery. But based on what I've read on studies that are being done right now, it seems like the timing for surgery is also a controversial kind of like issue when it comes to operating versus non-operating. So I wanted to know, how do you determine how early to operate? For example, in this patient, you noticed that his blood pressure was 40 to 20, and then you had to do aggressive resuscitation before operating. But what other parameters do you look at to determine whether or not you should proceed with emergency surgery when it's warranted? Thank you.
Great question. So a few things. One, I think for sure, we always say life before limbs. So in this patient, I thought that if we flipped him to do surgery, I think he would have died on the table or in the operating room. So that's why we aborted. I don't know if you got that from the start, but we didn't do the surgery because he wasn't stable enough. We brought him to the ICU instead. He never ended up making it to surgery. But so life before limbs, and about timing to surgery, that is controversial. I think the trend is to operate sooner than later. It used to be, wait for the swelling to go down and then go. And it seems to me that over the last few years, it's because of what Dr. Margetis said about time is spinal cord. The way I think about that question intuitively is, if that were my spinal cord, would I want someone to wait 48 hours? I would rather get the pressure off the spinal cord that's under compression as soon as possible. So this guy came in around 10 p.m. We were in the OR around midnight. By the time he was stabilized and had all of his scans and had this trauma eval. So, I didn't want to wait till the morning in this specific case.
Okay, thank you.
Sure.
Dr. Steinberger, it's Corey Gill. Do you mind if I ask just one additional question?
Please.
With all these different scoring systems for trauma, what happens when you have a discordance? One's telling you to operate, the other is not.
Oh, I haven't had that happen. The reason being, like, all of the scales are usually, they're all focusing on pretty similar things, which ultimately, you know, the scales are there to guide you. And I think you know, you have to be familiar with the scales, but to me, it's like, you know, each case is different. And a lot of the time, like we always say, patients don't read the textbook, because patients come in and like, maybe, you know, you have someone who like this, but they're 99 years old, you know, and then, you know, then you have to like, you know, flip everything on its head and say, maybe the best thing is to, you know, talk to the family and talk to the patient, you know. So, but as far as if there's discordance, to be honest, I haven't ever had that, because generally, they are similar. Like the Dennis or Denis classification, you know, often goes hand in hand with the TLIC score. If there was a discrepancy, I would probably, you know, if the patient's awakened, I'd probably discuss, you know, hey, here's a surgery we can do to stabilize your spine, but there's risks of surgery. Is this something you think you would, you know, here's the positives, here's the negatives. What, you know, give the patient all the information and let them make the decision with you.
Gotcha, makes sense. Thank you.
Absolutely. So I'll finish the talk quickly with minimally invasive spine surgery in less severe trauma. So obviously in that case, that's, you know, as high mechanism trauma you can get, but there's a lot of cases that are much less extreme, you know, burst fractures, compression fractures with retropulsion, and then you can sometimes get away with doing smaller surgeries. And basically my focus and my passion is with minimally invasive spine surgery. So, you know, what is minimally invasive spine surgery? We're trying to minimize the muscle disruption. We're not going to take the muscles off the spine to expose it. We're going to work through the muscle or around the muscle. You know, do we minimize iatrogenic instability or decrease adjacent segment disease? That hasn't been proven yet, but that's, you know, what we think is going to be shown when the time comes. For sure, blood loss, infection, incision size, length of stay goes down, minimally invasive spine surgery, and the recovery is what turned me on to it in the first place, because when I was exposed to minimally invasive spine surgery, the patients were just much happier, and that's what turned me on to it in the first place. And this is basically how it looks in the OR. It's like a video game. You have this fancy software, and wherever you put your probe, you're looking exactly. So you're trying to get a perfect pedicle screw, and you line it up on the sagittal view and the axial view, and you just place the screw in. And the good news for everybody on this, or at least most people on this conference, is the younger you are, the easier it is to adapt this newer technology. For sure, I've noticed that the younger generation just picks up on this quicker, and that's so you should all, you know, be optimistic about trying out these new tools. MIS is well established. I'm not going to go into this, but it is well established in trauma as well. And there's a 5-year study showing that we have non-inferior outcomes, meaning, you know, if you could do the same thing minimally invasive and open, and you're able to do it minimally invasively and have a non-inferior outcome, then, you know, it's worth trying and worth doing. In the big scheme of spine surgery, to deviate on my last slide from trauma, the hot things right now are minimally invasive surgery, which is the fastest growing market segment in spine surgery, robotics, virtual reality and augmented reality, and then improved navigation and intraoperative imaging. That's very exciting frontiers going on in spine surgery. This is a picture of a case who did an L4 to S1 instrumentation. And I'll end there to leave time for questions.
I have a good one in the box here. One is, can you do minimally invasive spine surgery at C1 and C2?
So the short answer is, in my opinion, no, but you can always find people who are willing to try things. To me, minimally invasive spine surgery works less well in the cervical spine because the cervical musculature is so robust. And the few times I've seen it, the patients had a lot of issues with spasm, because when you go through their muscles, they're all interconnected, you know, to the back of the skull and to the shoulder blades and the clavicle. You know, it's like, it's just a very muscular area that's intertwined in a very complex and actually beautiful way. So I think working through the muscle in the cervical spine, at least for me, is something that I haven't latched onto yet. So even like a posterior cervical laminectomy infusion, I'm doing open and not minimally invasive. But there are people who I'm sure have tried it.
Yeah, I'll say that in my experience in training, I did a handful of MIS foraminotomies in the cervical spine. But even in those, we ended up resecting more muscle than you would need to in the thoracic or lumbar spine. And I don't think it made a huge difference in the patient's pain or healing compared with, a small open foraminotomy.
Yeah. Secondarily, the way we dock our tube is with that, we put a small, very, very small tube down, and then we sequentially dilate tube over tube over tube until we have like an 18 millimeter corridor. And that first step of, blindly sticking a probe into the patient right next to the spinal cord, even though it's hard to kind of get it in that angle that could injure the cord, but it's certainly possible. So that's another thing that's been a turnoff for me to minimally invasive in the posterior cervical.
Yeah, well, once you put a dilator into the canal in the lumbar spine, you never want to use it in the cervical spine. So let's see, anterior approach versus posterior approach in MIS outcomes. Would you?
That's like
maybe we'll talk about lateral.
Yeah, that's a major discussion, not really for trauma, but so what is minimally invasive spine surgery? The funny thing about it is it's not really a definition, but to me, it's anything sparing the muscles. So you're not, doing your standard open middle of the back, splay the muscles open, look at the spine that way. So to me, and my definition, but that's not the definition, it's an anterior lumbar interbody fusion, a lateral interbody fusion, or a minimally invasive TLIF or PLIF. So meaning anterior side or posterior all have minimally invasive options. But that's like probably a much longer answer than I could answer right now.
Yeah, I think in the degenerative talk, maybe we'll get to that a little more. This is a good trauma question. Factors you take into account when discussing long-term neurological function and prognosis in spine trauma patients, and do you have any tips or approaches to those difficult conversations?
I'll definitely answer that, but I also, Con, I'm sure you have a great answer too, but I'll just tell you that, what I find complex about it is when a patient comes in with a spinal cord injury, and I've seen a number over the years, I'm always surprised at where they are in 3 months or 6 months. Some people surprise me for the better, and some people surprise me for the worse. There's some, what I thought to be minor injuries, and the patients don't recover as well. And there are some extreme injuries. I just had a patient with a cervical epidural hematoma. We did a C2 to 6 laminectomy fusion, and he was quadriplegic before surgery, and he regained his left side function in the hospital, but nothing on his right side. And I just had a 6-week follow-up, and now both his right arm and his right leg are anti-gravity. So I think, people surprise you, but I always paint a negative picture, because it's better, you'll learn that if you tell a family there's a 1% chance he's going to walk, and he walks, they'll be very happy. But if there's a 50% chance he's going to walk and he doesn't walk, they're going to be very upset at you. That, so I think I do a realistic prognosis discussion, but I in general err toward more grim, because I think it's better to set expectations low.
So just to add on what Dr. Steinberger said, I mean, for the, let's say, midterm, yes, I also, try to, explain that most of the spinal cord injuries, they don't have a good prognosis. But on the other hand, because many of these patients are young people, that, this injury is really devastating. It's very easy for them to go into depression. What I also tell them is that, this is the prognosis with the current state of the art, with the current, with what medicine has to offer nowadays. We don't know in 5 or 10 years what additional methods might be available. And we have seen the last couple of years, with the epidural spinal cord stimulation especially, we've seen that there is some hope that these patients might not be able, let's say, to go and play football, but they might be able to take some steps in the future as medicine and science evolves.
We have a couple other really good ones.
Yeah, I have to say the questions you're all asking are excellent. I mean, they're all great, and they're all hot topics that don't necessarily have, concrete answers. I'll take.
You take that dish question. I think that's a really good.
That's a great question. I think Con mentioned that earlier.
A little bit, yeah.
Khan, you want to take that one?
Yeah, sure. Yeah, history of ankylosing spondylitis or this. So these fractures, you know, in the setting of ankylosing spondylitis or this, they are highly, highly unstable. So in this, I mean, the whole spine, it gets ankylosed and it's like a long bone. Okay. So if there is if there is a fracture, and sometimes, you know, in such a setting, we might not be able to see the whole fracture. We might see just a fracture line going through the vertebral body. In such a case, you should always assume that this fracture goes through the spine, because it's like a piece of chalk. You cannot have it, you know, break halfway. It always breaks, you know, through. So these are cases that it has been shown in the literature that the patients do much better with surgical treatment. And what is important if you decide to proceed with surgery is to make a long fusion. You need to fuse at least 3 levels up, 3 levels down in the setting of fractured ankylosed spine.
I can address the question. I can address the question of David Para. What's your opinion about percutaneous drainage of spinal epidural hematoma? I think there's a few reasons I wouldn't consider that personally. First of all, if it's an acute epidural hematoma, then your chance of draining it is going to be slim because it's usually a thick clot. It's not liquid. And the second thing is, in generally, if someone has a spinal cord injury, it's not the time to be cute. It's time to, like, you know, look at everything. So, you know, you go in for an epidural abscess or an epidural hematoma, you get in there and sometimes, you know, it extends up higher than you thought or lower than you thought, or because it's a hematoma, it can grow, it can spread, it can thin out. So in an epidural hematoma, I go big and I go until I stop seeing blood. So if there's a C5 to 7 epidural hematoma, you may end up going to the top of C4 if there's still blood, or down to T1. And if there's still blood, you keep going until you get all the blood out.
Do you want to talk about this kyphoplasty question?
Yeah, I can take that. So although we don't do that frequently kyphoplasties, we send these most of these cases to our interventional neuroradiology colleagues, but we still do them from time to time. So when you see a kyphoplasty, when you see a compression fracture in an elderly patient, you should assume that, you know, there is generalized osteoporosis. So when you do a kyphoplasty, you might address the fracture at that level, but because that vertebra becomes stiffer, it might lead to a fracture in the adjacent segments. So in these cases, if I decide to do a compression fracture, I always make sure that the patient have a thorough osteoporosis workup and osteoporosis treatment. I take for granted that they have untreated osteoporosis. So that's the way I treat these patients. And I also, you know, warn them to be very careful to avoid any falls until the osteoporosis is adequately addressed.
And what do you each consider to be your indications for using a kyphoplasty in a compression fracture setting?
I will use it if I believe that there is osteoporosis. I'll go for ladies over probably 75, and for men a little bit, I don't know, around 80 years of age, I would say.
I just want to say again that all these questions are outstanding, and you're clearly all a bright bunch, and I'm happy you joined us, and keep being inquisitive and asking great questions. And just quickly to Clementine.